Okay, I hope that was inspiring for all of us. I know it was for me. I'd like to invite the panelists and the moderator for the next session to come on up. So our next session is on epilepsy. And our moderator today is Dr. John Rolston. He's a neurosurgeon that specializes in epilepsy surgery. And we're going to have virtual panelists and in-person panelists. And just to show you how collaborative this type of work is, on our panel, we have neurosurgeons, neurologists, engineers, and neuroradiologists. So I'll let you guys try to figure out who's who in the panel. But for now, I'd like to introduce Dr. John Rolston to introduce the panelists and get it going. Thank you.
Right, so thank you for that introduction. So I'm John Ralston, and I'm a functional and epilepsy surgeon from Brigham and Women's Hospital and Harvard Medical School in Boston. Could we get that first slide up? There we go. All right. So let's get those. So epilepsy is a critical problem in our country, and I never turn down an opportunity to sort of evangelize about how important this is and how we need brilliant people like the people at this symposium and the people on stage and remotely to focus on this. Epilepsy is very common. It affects about 1 in 26 people during their lifetimes. That's about 1% of our country, 3 million adults, 500,000 children, and it severely impacts these patients' lives, including a social stigma, difficulty completing school, finding work, there's driving restrictions, and it's deadly. So all these photographs on the page here are people who have succumbed to something called sudden unexpected death in epilepsy, which is a basically induced mortality from seizures directly. And that occurs in 1 in every 1,000 patients every year, and with patients that are waiting for surgery, it might be as high as 1 in every 100 patients. The first thing we do to try to treat epilepsy is medications. About half of patients are seizure-free with that first medication and maybe a few more percentage after that. But once you fail 2 medications, the chance of being seizure-free after that is very small. And this hasn't changed with new anti-seizure drugs that have been developed over time. So there's been a whole slew of new anti-seizure medications with different side effects, but the efficacy and that ability to create a person that's resistant or that's sensitive to these medications has really not budged in the past 20 plus years. So this led the main international organization that researches the treatment of epilepsy, the International League Against Epilepsy, to have this definition for refractory epilepsy, which is that the failure of adequate trials of 2 tolerated, appropriately chosen and used anti-epileptic drugs, either alone or in combination, to achieve sustained seizure freedom is refractory epilepsy or drug-resistant epilepsy. And again, this is about 1 of every 3 patients with epilepsy that will receive this diagnosis. If medications don't work, that's when we start thinking about epilepsy surgery. And fortunately, it's very effective. There's been 3 randomized controlled trials showing that we can achieve about 50 to 70% seizure freedom with surgery versus continued medications. There's also 3 neuromodulatory therapies that are available with class 1 evidence supporting their use. The number needed to treat for epilepsy surgery, which is something we use in the healthcare field, is 2, which is on the order of something like Tylenol and probably better than opioids. So with all this evidence, as well as case series that preceded this, we've came up with a set of guidelines in 2003, a joint set of guidelines from the AAN, the AAS, and the AANS, saying that if you are declared drug resistant, you should be referred for surgical evaluation. Despite the fact that this surgery is known to be so helpful, the average time in our country to being referred for epilepsy surgery is 20 years. So this is a public health crisis. We have an effective treatment that is not being utilized anywhere near where it should be, and people are dying because of that. So this is, this is in part due to what we think is this sort of consistent fear of epilepsy surgery on behalf of patients and the referring providers. So epilepsy surgery, it's somewhat invasive. It's a neurosurgery, and despite the benefits, there's risks. And those risks are unpalatable to a lot of patients, and the benefits might not be sufficient enough to drive them to surgery. So anything we can do that changes that balance of risks and benefits will drive more patients to seek treatment. And that's our hope with something like focused ultrasound. And we've seen some benefits already with other minimally invasive or less invasive treatments, such things as stereo EEG, which is a less invasive way to find out where seizures start from, laser ablation, which is a less invasive way to remove pathological tissue, and now, hopefully, focused ultrasound. So our goal for today's discussion is to introduce some of the people that are on the leading edge of using focused ultrasound to investigate and treat epilepsy. Maybe talk about these different aspects of this, so the goals of therapy, what are we actually trying to do when we use focused ultrasound to treat these patients? What are the role of mechanistic studies here, whether we should be focusing on that versus doing direct human trials? What the ideal sort of system or treatment platform would look like, what are we aiming towards? And then what is going well in the current regulatory environment, the current funding environment right now that is enabling these studies. So with that, I'd like to start with our first speaker, which is Ellen Bubrick, also from Brigham and Women's Hospital, and she'll be joining us virtually.
Hi there, thanks very much for having me.
I think we can get her slides up. Yep, there they are.
Here we go. Great, thank you. This is a picture of our system in our trial at Brigham and Women's. You can see that was my research assistant, Patrick Troughton, and Jason White, the ultrasound physicist. And that sort of large metal object there is our homemade focused ultrasound system for low intensity, focused ultrasound for epilepsy for neuromodulation. You can see we have it set up in a system where we get a pre-procedure MRI, and then we do co-registration with the transducer via our neuronavigation system, pointing at 4 selected predetermined areas of the hippocampus that we sonicate. One more slide. So just very briefly to introduce what we're doing, as Dr. Olson said, I'm an epilepsy doc at Brigham and Women's. My interests have been in trying to develop treatments for patients with drug-resistant epilepsy, and focused ultrasound has been really, really exciting in this way. But we're still very early in the process. We're doing a safety trial. Our trial is looking at sonicating over 6 sessions over 3 weeks to the hippocampus in patients with mesial temporal sclerosis, mesial temporal epilepsy. So you can see a picture there. On the bottom is just a picture of the 4 we predetermined the spots along the hippocampus. And then you can see the picture there of the beam going directly through the temporal acoustic window to hit the hippocampus. We chose temporal lobe epilepsy for many reasons. As many of you know, it's one of the most common types of epilepsy, but also the temporal bone in the temporal acoustic window is perpendicular to the ground in humans, and it's very thin. It's the thinnest part of the human skull. There's no trabecular bone there. So it makes for easy prediction for the pathway for the ultrasound waves to the hippocampus and sort of a direct shot. Also, the hippocampus is such a fascinating organ to study. And so it helps also with trying to prove target engagement, which is something that's difficult with focused ultrasound, especially low intensity focused ultrasound, because we can use the hippocampus to study memory changes, mood changes, changes in EEG, changes in functional connectivity of functional fMRI, resting state functional fMRI. And then there's just a quick picture of our study protocol. We do a pre-study MRI, structural MRI, and the resting state fMRI. And then we monitor for a while and log seizures. And then we do 6 treatments over 3 weeks. And then we watch the patients for up to 6 months. Again, this is just a safety trial. So we're first just looking at establishing safety. None of our patients have had any safety issues. All of their MRIs have been fine. And there's been no increase in seizure activity. In fact, we've been getting some promising data in terms of seizure frequency, but it's just very, very early to even say anything. But so far, it looks to be safe, even in patients with a hot, hyperexcitable hippocampus. And so we are still actively recruiting and hoping to move to the next phase soon.
Thanks, Alan. Let's move on to our next speaker, Vibor. He's here.
Thank you, John. Thank you for the invitation. Let's have the next slide, please. So the application of focused ultrasound for epilepsy that we are interested in involves ablating part of the thalamus called the anterior thalamic nucleus. So from anatomy standpoint, this area is shown in dark brown. It's very close to the ventricle and sits on top of the dorsomedian nucleus, and very close to the mammalothalamic tract. In fact, part of the mammalothalamic tract goes towards the anterior nucleus, as you can see in the cartoon. Next slide, please. So we embarked upon a phase 1 clinical trial of anterior nucleus thalamotomy in patients with treatment-resistant epilepsy. Next, please. Is it possible for me to have? Thank you, sir. So these are patients who have disabling medication refractory epilepsy, partial or focal onset epilepsy with secondary generalizations, with a high seizure frequency, 4 seizures or more per month, and who were stable on medications. And we are thankful to the foundation for supporting this work. As a part of the regulatory approval for the IDE, FDA allowed us to do this study in phases. So 1 patient followed by 3 and then followed by 6 with a total of 10 patients. Currently we have enrolled and treated 2 patients in this trial. First patient had a follow-up of 2 years and the second one 1 year respectively. We did not observe any serious adverse event. 1 patient had a decline in verbal memory. And as far as preliminary efficacy goes, the first patient had a reduction in seizures. He used to have 4 to 6 seizures a month and has been seizure-free for 2 years. The second patient used to have high seizure frequency, 90 seizures a month, and are currently at 4 to 6 seizures per month. So I want to remind that this is a unilateral only, so one side of the thalamus. A T2 weighted image showing the thalamus, anterior nucleus of the thalamus with the ablation inside, and in the right-hand panel showing some changes with diffusion MRI. So this is a patient who we treated in the trial, 39-year-old right-handed man who had a 27-year history of seizures, which were impaired awareness, and patient had failed VNS before and actually underwent a workup with invasive intracranial monitoring as well elsewhere. And the seizures were very high in frequency, and during the seizures he couldn't speak, there was confusion, and he retained some language comprehension. During the invasive monitoring, it was found that the seizure onset was multifocal and actually involved some of the language areas. So the resective surgery, as John mentioned, was not an option for this patient. They underwent deep brain stimulation, which is also approved by the FDA, so anterior nucleus deep brain stimulation, which improved their seizures dramatically. But unfortunately, the hardware for this patient was infected, and the DBS had to be removed. Once the DBS was removed, unfortunately, the seizures came back, and the patient had to be started on polypharmacy, and the regimen is listed here that included very high doses of these medications. And so we enrolled the patient and treated them with unilateral focused ultrasound ablation of the left anterior thalamic nucleus. Patient did not have any immediate side effects or any SAEs. These are the pictures showing the T2 weighted axial and sagittal images with the lesion in the anterior thalamic nucleus. And we did a seeding of this lesion to see what all tracks and networks were involved, and showing the known connections of the anterior thalamic nucleus. Thank you.
All right, Diego, let's go.
All right, so thanks a lot for the invitation to be here today. So a disclaimer, I'm an electrical engineer. I'm very far away from patients. So what I do is I develop ultrasound devices that maybe one day the clinicians can use to patients, but at least until now, I've been more focused on preclinical applications. And, okay, I think the wrong slides. Perhaps you can switch to my slides, please. Yes. So indeed, so as I mentioned, I work on the electronic side and on the transducer side of focused ultrasound, and specifically on microchips. So as you saw also from the Medtronic talk before this one, the evolution of the pacemaker, right, from a big device down to a small device. That's kind of the idea. So by exploring microchip technology, this allows for the miniaturization of the ultrasound hardware, and also for more power efficient or more energy efficient devices that can require ideally smaller and smaller batteries. And in the context of epilepsy, what I was asked to provide was, let's say, a dream scenario from my perspective at least. And this is what I thought of, and this is also what I'm already doing in my lab with a few collaborators, is to develop this subcranial chip. I know this goes a bit against what you have been discussing about the non-invasiveness, but bear with me for a while. So the idea is to indeed make these small chips that can fit under the skull. And of course, if we go under the skull, we are being more invasive, but at the same time, we are alleviating the need for, let's say, this very more complicated neuronavigation demands, because we no longer have to deal with the skull in the propagation path and the distortion of the sound beam that it leads to. Simultaneously, we can also explore the emergent field of brain-machine interfaces, right? You all know Neuralink, I suppose, where this idea of making chips to record signals from the brain. In the case of epilepsy, we could also explore this microchip technology to record EEG signals, for instance, that could allow us to detect and decode the location of the onset of a seizure, and then use the focused ultrasound to stop the seizure, if possible. Of course, if we are under the skull, this also enables the ultrasound frequency to scale up, right? So we no longer have to worry about the skull, so ultrasound frequency could increase by, say, 1 order of magnitude, while still allow us to go deep into the brain. So this could potentially lead to higher precision. But of course, there are challenges here, and the first challenge that you might already be thinking, and it's also on the screen, is how to power these devices, right? So if we place something below the skull, we have to provide energy for its operation. So this is one of the challenges, both in terms of the size of the battery and how long it can last. Also target localization, so if we think about closed loop operation, how could we use the information from recordings that we do and on the fly detect the seizure and know where to treat? And finally, biocompatibility. So if we are indeed invading a bit the space of the body, we have to worry about biocompatibility. And the main material that produces ultrasound contains lead. So there are also research being performed and also already commercially available materials that do not contain lead. So it's a matter of trying to incorporate these materials. But I did not mention indeed that even though these devices are below the skull, they are above the dura. So we just need to bypass the skull, okay? And just to show you an example of what we already, okay, animations are a bit reversed, but this is the idea, right? So I know this is an imaging, a sketch of an imaging transducer, but this is the idea. We look at the electronics, we turn it into a chip, we look at the transducer probe, we put on top of the chip, and now we have a very small device that can basically do beam forming and focus ultrasound and steer the beam. So just like you can do today with, let's say, more handheld or large devices. So this is what I have to say today, but just a final remark. So even though this vision is to place this device under the skull, the same principles can apply if we do transcranial, right? Everything that we do here to optimize power efficiency and precision can also translate into either, let's say, a device that goes under the scalp or or above the scalp, or even to a handheld platform that patients have at home. So because one advantage of this microchip technology is also cost. Because they are smaller, they can be mass-produced, let's say, with considerably lower costs comparing to more discrete implementations. So this is what I see for, let's say, the hardware part of this field or where it can potentially go. Thank you.
Thank you. And it looks like we skipped through Dr. Yu's slides, so if we can go back on those slides to get Alice's slides.
Hi, everyone. I'm Dr. Yu from Taipei Veterans General Hospital. I just want to make a short brief of our works by using transcranial focused ultrasound in the treatment of patients with epilepsy. And in the beginning, we started with PTZ animal models, and as we know that it has been proved that in the PTZ animal models, focused ultrasound has the effect to inhibit the epileptic activity in 2012. Yeah, and in our study, we first designed several protocols to deliver the focused ultrasound on the rat brain, and it has been completed and published. And our second step is to apply the experience to the human by using the intracranial SEEG studies. We use those group of patients because we have the real-time intracranial stereo EEG recording. It is more direct compared to the before and after treatment by using scalp EEG or functional MRI. And so in our second step, we enrolled 6 cases and proved it is safe to deliver transcranial focused ultrasound to a patient who underwent intracranial EEG recording. And we also demonstrated some power spectrum change before and after treatment of the focused ultrasound. And there are a lot of data that we can process. And I think later we will discuss more about how to evaluate the neuromodulation effect of focused ultrasound. It is quite difficult. But I think in our group, I think we are lucky we choose the intracranial EEG to be our first step. And it did give us some information that focused ultrasound can modulate the epileptic brain. And our third studies, we use the KA model, and we deliver the focused ultrasound 5 minutes 3 times, and separated it by 5 minutes rest. And in this study, the effect of burst suppression or spike decrease lasted for 7 weeks. So we apply this protocol again to the human, and this is the 4th study that we are now ongoing. We have enrolled 4 cases, not in the intracranial EEG recording, just the outpatient clinic who were drug resistant, and we used the crossover studies and separated by 1 month treatment. And after that, and when we were analyzing our pilot study of focused ultrasound and the 6 intracranial EEG study, we found that focused ultrasound can also modulate the network. If we use the same analyzed method to compare the cortical evoked potential we obtained during intracranial EEG recording, and we can compare the network evoked by these 2 methods. We want to know, I think we have the chance to know that mechanical stimulation and electric stimulation, the effect, the similarity or difference between these 2 methods on epileptic brain. And also, we are also interested in the lesioning effect by the high intensity focused ultrasound. So we are now waiting for our IRB reviewed to treat our patients whose epileptogenic foci have been proved, and we want to lesion on this area. And this is so far our group trying to do to develop the treatment by using focused ultrasound. Thank you.
All right, thank you. And next we'll go to Dr. Fountain from University of Virginia. Let's get his slides up. I think Dr. Wintermark is not on Zoom that I can see, unless he's hiding. So let's skip over this one to Dr. Fontaine.
Hi, thank you. Thank you for inviting me, and I'm sorry that I'm not able to be there in person. And also, I don't have slides, but my talk's pretty straightforward, the most straightforward I think we can be. And our project has been to do lesioning in patients with epilepsy using transcranial MRI-guided high-intensity focused ultrasound. So the traditional system, as I would see it, it's a long-standing study now that's moved ahead quite a bit recently. And it's a pilot study treating up to 20 people with focal epilepsy, and is now a multi-center study. So originally it was just us, and we had a lot of trouble finding accessible epileptic foci. Now with autofocusing, we can identify and get to a lot more foci. And besides our institution, it's also being done at Stanford with Bob Fisher, at University of Kansas with Michael Kinsman, and at Mayo Clinic with Jamie Van Gompel. And as I mentioned, it's an open label safety and feasibility study in adults who have at least 3 seizures per month with intractable epilepsy with a known focus. These are patients who have already been selected for surgery, and our job's just to provide the lesion. The easiest way to conceptualize this, and the most common patients have hypothalamic hamartomas, which are located right in the middle of the brain, in the hypothalamus, and for focused ultrasound are actually easiest to target, although it's an uncommon cause of epilepsy. But in general, to be in the study, they have to have an epileptic focus that's known and identified and is more than 2.5 centimeters from the skull, because that's the accessibility or the treatment envelope for high intensity focused ultrasound. In our case, after a screening and enrollment baseline visit, then we collect seizure frequency for up to 2 months. Then they come in for a single focused ultrasound treatment, that a single session, might be multiple treatments, but a single session. Are hospitalized overnight and go home the next day, and then return, actually have a phone call at 1 month, then return at 3 months, then a phone follow-up at 6 months, then return at 12 months. And besides their clinical seizure frequency, the most important thing we're doing is follow-up MRIs, look for evidence of the lesion, but also neuropsychological testing, a QALY 31, which is a quality of life and epilepsy scale, and the Columbia Suicide Severity Rating Scale, which we now do in all epilepsy studies. And so far, we've treated 6 patients and been able to provide a lesion to each patient. How effective it's been has been highly variable because we've treated a whole variety of lesions, and we'll have to wait until the final outcome. And in terms of the hurdles we've encountered and the things we might share with everyone to help them understand it, the most problematic thing has been that although it's non-invasive really, it's actually kind of minimally invasive because their head has to be shaved. They have to have a frame, and they have to sit inside the MRI magnet for a long time, for hours at a time. So that's been our biggest hurdle. Once people realize that, they're not as enthusiastic to participate. But as I mentioned, having the autofocusing that can deliver a higher energy to the regions we're interested in has been really useful. Thanks.
And thank you. So is Dr. Wintermark there? Okay, so it looks like we lost Dr. Wintermark from Stanford, so let's go into some questions in the meantime. And if he pops back up, we'll give him an opportunity to discuss his slides too. So I can kick off some sort of discussion questions. One is that all these are really exciting studies, but it seems like there is not a high number of patients that have been enrolled in many of these studies. And is that a reflection of still these limitations on things like head shaving? Or is it other aspects of just finding patients with the appropriate phenotype, like mesial temporal sclerosis? Why do we think it's that we're not more easily able to gather a lot of patients for these studies? Maybe we'll start with Vibors.
That's a great question, John. And And certainly we have had our fair share of patients who showed up for screening and assessment and didn't follow up afterwards. And as Dr. Fountain mentioned, some of these patients were not keen on having head shave. That seems to be a big barrier for a lot of these patients. And then there are study-specific concerns as well. As we all know, these patients don't drive. And so having a reliable caregiver that brings them to the hospital and do all the assessments, that has been a challenge for some patients as well. And, overall, it somehow the center has to figure out where this sits in their treatment paradigm. When patients are undergoing assessments and evaluations, and where does the enrollment in the trial option appear in their protocol, again, is something that it takes some effort for the team to realize and implement.
I see a question from the audience.
I was just hoping to ask about setting aside hypothalamic hamartomas, which I think are phenomenal, at least potentially phenomenal in terms of why they make sense. Given how minimally invasive lit therapy already is, and it doesn't involve a head shave, and they get to be asleep for it, what do we think actually, do you mind if I ask a two-part question?
Please do, yeah.
So first of all, what do we think the potential advantages of HIFU over lit are likely to be? And then second of all, do we think that in a paradigm like this where we are not as concerned about immediate term clinical feedback and where one of our main barriers to achieving a high volume of tissue ablation in HIFU is patient tolerability, right? I mean, because as the skull starts to shut down, we have to start really jacking the energy and eventually they just tap out. Given that epilepsy patients are going to need a higher volume of tissue ablation, do you see feasibility for general anesthesia for these patients? Could we overcome some of these barriers by saying, we're not going to be doing tremor assessments in you, so we can put you to sleep and see how we do?
Great. So I think to paraphrase the two questions, the first one, since lit is so good, why are we bothering with focused ultrasound? And then the second one is, why can't we use general anesthesia to really get big ablation volumes? So I think Nick probably has some good ideas about that. Dr. Fountain?
Yeah, so that's a very astute observation. One of the problems is that I've been contacted by many people, particularly abroad, but really across the country, who want something easier than lit. And it's pretty hard to say this is easier than lit. Obviously, lit's pretty, it's not outpatient therapy, but compared to focused ultrasound practically is, I guess. So that is really a big barrier, and I think it's true. And we're still, the use of autofocusing has just been fundamental. Before that, everything was problematic. So I would really say we've just started this year in a new way to approach it in a way that we can give people a bit more assurance. But no matter how you slice it, it's definitely more cumbersome than lit. But I do think there's a couple of places. For instance, for a hypothalamic hamartoma, something deep, it does make sense to have something non-invasive, even though lit's still pretty minimally invasive. The second thing I would say is that lit's not available across the world, so it's not available in England just yet. It just became available, but only on a listed or ration sort of basis. So there's opportunities there, but really I think the true answer is technology has to get better, particularly stopping the head shaving, but probably other aspects of the technology. And the second part of the question about general anesthesia is correct. So there's no reason not to do general anesthesia except for the skull heating. So if there are people we've done who, if they did have general anesthesia, I'm afraid they might have had a lot of skull heating. That's less of a problem now than in earlier versions for all those technical reasons. But I'd say that's true, so it makes sense that once you know the anatomic target and you do the MR thermography and identify the target, then you're going to ablate it regardless. So I think those are astute observations, and two things have been difficult to overcome. There's another kind of parallel to that, something also not so obvious, is that the people who tend to want this, to participate in the study, tend to be people who are anxious about other therapies, because they're not really thinking about this being a research therapy and very involved. And once they learn how involved it is, either they don't want to do it or maybe we don't want them to do it because they're so anxious about standard therapy. That's another hurdle.
John, can I mention something along
Please.
those lines? I also just want to say, I'm always teaching our fellows not to underestimate how invasive lit is. We call it minimally invasive, but if you have enough patients and you undergo this procedure, you will have a hemorrhage. You'll have people who get really hurt. So it's much better than open craniotomy for a lot of patients, but it's not without risk. So the difference of incisionless surgery by ablation versus lit can't be underestimated. We say lit is like, oh, it's so minimally invasive, but it's still a risk to the patient. And there are even less invasive measures.
And so a related question to that, so Ellen and maybe Alice too, do you see your therapies, more of the neuromodulation ones, as competitors to something like laser ablation, or are they their own category now? Like what's the yardstick that you would use to measure your devices on, or your therapy?
In terms of efficacy?
Yeah.
I mean, we don't know yet. We don't know yet efficacy of low intensity ultrasound for treatment of epilepsy. We're just looking at safety still, but I don't see them as competitors. I mean, I'm the director of the epilepsy program at the Brigham. I love epilepsy surgery. So when epilepsy surgery works, that's great. And that's still something we've tried to do first, if we can go for cure. But you know, they have some troubling outcomes in some patients, and outcomes vary. And so if it fails, or if the patient isn't a candidate, then I'm thinking about other options for drug resistant epilepsy. So I don't see them as competing. Low intensity ultrasound is a form of neuromodulation, so to me it's different, and they don't necessarily have to be mutually exclusive. Someone who's had surgery may still be a candidate. There's a lot of skull issues we'd have to get through with the breach there, but still could be a candidate for neuromodulation. So I don't see them as competitors, but maybe as complementary.
Well, thanks everyone for all the great questions and commentary. We have 5 seconds left, so we'll end early. All right.
Thank you. That was a really interesting discussion. And, you know, the Focused Ultrasound Foundation is working closely with the American Epilepsy Society and the Epilepsy Foundation to spread the word about focused ultrasound, engage with their teams to, you know, educate all of our communities and work together. So we look forward to ongoing projects in the world of epilepsy.